she'd never been to the hospital because the hospital was, in her point of view, where you go to die.
You have done work with creating programs to help with topics such as teen pregnancy prevention and breastfeeding promotion and like contraceptives. These are topics with a lot of stigma, not just abroad, but in conservative communities in the US as well.
Yes.
So when you present these topics, are you met with a lot of backlash and that kind of makes it difficult to implement these programs?
The United States has a lot to learn from healthcare solutions that are developed in lower and middle income countries. It's work that I love partly because it's uncomfortable. And I'm pretty comfortable talking about uncomfortable subjects and trying to create the space for other folks to enter into that dialogue and exchange and listening and learning and sharing. Global health work is waking up every day and knowing that ethically, there's not always a right answer, and you have to be mindful that by doing something seemingly good, you could be doing harm at the same time.
Hey everybody, welcome back to SheSpark, where empowering conversations unfold. Today's guest is Kristina Graff, a global health professional. Kristina has her BA in psychology and Spanish from Duke University and her MPA and certificate in health and health policy from Princeton University. Kristina is currently the social impact leader over at Yoga Alliance. However, she has worked with so many organizations both in the US and abroad to help implement extremely important health programs for historically marginalized communities. And in this video, we're going to talk about why exactly that is so important for not only the present, but the future of our world too. Hope you enjoy.
Hi everyone, welcome back to SheSpark. Today we are here with Kristina Graff. Kristina, how are you?
I'm doing great, thank you.
Glad to hear that. So you are a global health professional. Can you tell us exactly what that entails?
Yes, so being a global health professional can mean a lot of things. I think what a lot of people picture is a clinical professional, like a doctor, a nurse, a physician's assistant. I actually am in the management and coordination side of global health. So I'm a public health professional, meaning that I work on health programs and interventions that are intended to increase equity in health and well-being so that people around the world have really equal access to live a healthy and fulfilling life. And the way that works for me is that I work with clinicians who specialize in delivery of healthcare, but I also look at the systems that feed into that and what makes some individuals or some communities either more vulnerable to health issues or more likely not as able to access resources through no fault of their own, usually living in environments that are under-resourced and aren't getting adequate health care.
And what exactly led you to kind of want to go into this field?
Yeah, this is a field that I 100% stumbled into. I had no idea that public health existed. Global health wasn't even called global health when I started. It was called international health, which is kind of interesting in the shift.
Mm-hmm.
In terms of a little context, since I was very young, I was really interested in professions that were about mutual aid and equity and social justice and what are sometimes called the helping professions, like therapy and mental health. I didn't know what to call those things at the time, but now that I know those terms, I understand that that's what I was passionate about. I was really interested in social inequality in the world and why was it that in a world where we have enough, not all people had fair and equal access to resources and supports. But I wasn't particularly interested in health, I thought, because I just wasn't a fan of science. So I was a kid who loved school in general, but my least favorite class in school was always science. So I thought if I wasn't interested in science, then I couldn't go anywhere near health or healthcare. It just didn't occur to me other than the mental health space. I did peer health education when I was in college. So even though I didn't plan to go into health professions, I found the subject of behavior change communication really interesting. I was quite drawn to this idea of what what engages people with interest in the subject. And so just as an extracurricular activity, I started doing peer health education pretty early in college and ended up through again, good fortune, getting a job in the health education office. The other thing that I think contributed to me finding myself in global health was that, again, since I was very young, I have loved learning about cultures and learning about different places around the world. And I think this is partly thanks to my background and my mom. She came to the US from Venezuela when she was pretty young, and she married my dad, who's from the US. And my mom was always very tapped into the international community in general. So I think it was sort of built into me, this curiosity and interest about places and communities and cultures beyond my own environment. But then I think the pivotal point was when I studied abroad. So I went from this world that was very bicultural in my own home to choices in my own life where I got to go out and see a little bit of what the world had to offer and travel. And that just lit a fire in me that has not gone out yet. I love traveling to new places, and less as a tourist and more as just a human being moving through the world, connecting with people across different cultures, and going to lesser known places, and specifically in public health, really going into communities that seemingly are very different from my own. But in fact, the more I've gotten to see the world, the more I realize like humanity is more alike than it is different.
That's great. And you have taken time, like you've been to countries all over the world, right? Africa, Asia, and Latin America.
Yeah.
Like during your time there, did you notice extremely drastic differences in the health programs available there in contrast to what's available in the US?
So I'd say in some ways, yes. In terms of what resources are available, and I'm going to talk specifically now about middle and lower income countries as compared to higher income countries like the US. Primarily, I have worked in regions that are resource constrained, and that's why there are efforts there to make healthcare more equitable. But like an example is there might be equipment that is single use in the United States. So, a piece of equipment that you use one time and then you dispose of it. And that same equipment, when used overseas, might be used safely multiple times. So there might be entire sterilization procedures and reuse procedures, so that there's less waste. And I've heard that too from folks I've worked with who've been in biology labs and the like, that one of the most tangible examples is things like what resources are available, but it's not just a less and more thing. Sometimes it's a better, more effective use in more resource constrained settings. But another big difference that I saw in some of the places I went was just the limited access to healthcare, like what it takes to get to go to the hospital or why you would go to the hospital was so dramatically different. And one example from early in my career that really stuck with me was when I met a patient who said she'd never been to the hospital because the hospital was, in her point of view, where you go to die. And so that's quite a difference. But in some other ways, there's not actually as much difference as we tend to think. And the United States has a lot to learn from healthcare solutions that are developed in lower and middle income countries. A couple of examples: the diagnostic capacity of healthcare providers in settings where there aren't 20 different tests available on hand can actually be stronger because healthcare providers are using like their training from their knowledge base and their own critical analysis and not leaning as heavily on tests. And I've definitely heard this both from friends of mine and people in my world who have come from other countries and prefer to go to healthcare in their home country, which might have officially fewer resources, but they feel like the healthcare is better because they're getting more thoughtful attention from the providers. I've also heard this from providers who have volunteered from the US to lower resource settings, that they feel as those differences actually yield more thoughtful practice of medicine. So as much as global health programs historically have been pretty colonialist, where there's like folks from wealthier countries going in to teach folks from less well-off countries, there's now, thank goodness, a growing awareness that folks from more resource-constrained settings have much knowledge and wisdom to teach folks from more resourced environments.
That is really interesting because me personally, as someone who has grown up in the US her whole life, I've only really heard of how, the US's healthcare is better and we have like better programs available and there's nothing we can learn from other parts of the world. So you saying that is really, really interesting to me and I will definitely be looking into that more.
That's great. That's great. Yeah, I'm really happy to see that getting more attention on the global health scene.
Mhm. And can you tell us what exactly your role was in these other countries while you were advocating for improvements in women's health programs?
Yeah, so I've had a mix of roles, and ultimately, again, this is reconciling with a pretty colonialist orientation that global health has had historically, and I think now is revisiting and trying to correct. Um, the roles I had were usually working behind the scenes to support people in partner countries who had the deepest wisdom about their own communities and the greatest knowledge of how to problem solve. And my role was a mix of advocating for the resources that they were seeking to address preventable health issues, because again, I was often with institutions that had maybe resources to offer, but not all the solutions in their pockets.
Mhm.
That's a really general answer. So I'll give a couple of examples of what that looked like. And it depended on the organization where I worked. I worked in an organization called Engender Health, which worked on sexual and reproductive health at the time I worked there, and also maternal health. And what we did was worked with partners in the ministries of health in different countries to help make family planning and contraception available to the people who most needed it in the places where they might have their only encounters with the healthcare system. So I mentioned the hospital is where you go to die
Yeah.
example. So if folks are going to have one encounter with the hospital and they are clearly needing and seeking contraception, one of the things I helped work on was supporting a training program that would introduce family planning counseling and the provision of family planning into emergency obstetric care settings, so that you've got folks who are dealing with emergencies, and what you're asking is for them to add a little time with the client to actually discuss these methods with them. That was, I think it was called like healthcare delivery. That was my work in the healthcare delivery end. I worked at an organization called Women's Dignity in Tanzania a few years later, just for a year as an intern. And my role there was storytelling and communications around a preventable but very devastating childbirth injury called obstetric fistula. And there, my role had three purposes. One was getting attention and funding from international organizations and donors to direct resources to the issue. And that's where I, as one of the only not local to Tanzania people, fit in, was really doing that communication for an international and largely US based also audience. Another role was communicating for advocacy for government action and investment in the health sector, focused on the most economically marginalized communities. So sometimes there was there were enough resources to do more and do better, but they weren't always being allocated. So the organization I worked for did a lot of advocacy, and I did everything from like copy editing to formatting and writing documents that would be persuasive. And then there was some storytelling I did that was focused on building community understanding of what were the cultural and social factors that contributed to women enduring preventable childbirth injuries. So it was not my role to tell people what to do, but there were longstanding practices that put women at risk. And so part of my job was to hear stories and then find the themes and then share the stories along those thematic lines in a way that might resonate.
So one anecdote you just gave caught my attention. You mentioned how once you worked with an organization advocating for a government better allocating its resources when it had enough resources, but not enough progress was happening. Is
Yeah.
that something you see a lot?
Yeah. Yeah. And it hurts to see because again, my belief is that the inequities in the world are not due to a lack of resource. There's enough to go around, but it's how we distribute it that is I think where we have a lot of improvements to make. And so there are certainly countries that have fewer resources, and like I'd say in most cases, it is also not the fault of those countries alone in mismanagement. I've mentioned colonialism a few times and the importance of it in global health. One of the things that I understand more and more every year and every day is that the history that led certain countries to have more or less was about abuse of power and exploitation of resources. And some countries were exploited for their resources and essentially plundered, and then others like got all the stuff, right? That said, now there are these big health programs to kind of redistribute, and sometimes in the US and elsewhere, the resources don't always get allocated to where they're most needed. And I mentioned that following that, I worked somewhere that we focused on bringing primary health care to communities that didn't have access to their local health system.
Mm-hmm.
And one of the things that I felt most conflicted about was that it was meeting immediate needs in a very meaningful way, and sometimes in a life-changing or life-saving way. And it was also enabling the governments of those countries to continue to not serve the communities because someone else was coming in and doing it. So I think also global health work is waking up every day and knowing that ethically, there's not always a right answer, and you have to be mindful that by doing something seemingly good, you could be doing harm at the same time.
That is devastating, but hopefully we're moving past it a bit as a society.
I hope so.
Mm-hmm. And so you have done work with creating programs to help with topics such as teen pregnancy prevention and breastfeeding promotion and like contraceptives. These are topics with a lot of stigma, not just abroad, but in conservative communities in the US as well.
Yes.
So when you present these topics, are you met with a lot of backlash and that kind of makes it difficult to implement these programs?
Yes, and I'd say especially as an outsider, I've assessed a lot like what should my role be in this work, and if you are not a member of the community that you're working to support, you really have to evaluate, okay, who should be driving the bus and who should be like a passenger and a supporter, right, or helping fuel the bus or whatever the thing is.
Mm-hmm.
I'd say I've definitely, and I do live in the US and am a member in some senses of the communities that I care about. I work for the New York City Health Department and was a New Yorker myself, living with my own reproductive and maternal health experiences. So that was really helpful because I got to be living the experiences at the same time as I was working on them. And yes, so resistance, absolutely. And I think that when it comes to reproductive health, sexual health, maternal health, really anything to do with certain parts of the body, it gets super sensitive. And there are certainly perspectives that if you give too much education or resources, it will foster negative or self-destructive behaviors. Not only do I disagree with that, the public health evidence shows that education and resources is associated with positive changes in these areas, not negative ones. So how to address the stigma? There are a few ways. One of the first things is if it's not your own community, it's finding the folks within the community who believe strongly in access to the services or resources, right? So as an example, let's say family planning and contraception. Every community I went to, no matter how conservative, there were folks within the community, often women, who felt this was very important work and they were passionate about it and they were advocated for it. And so the job there is like just back it up, right? Back it up with whatever they need, because they know their communities best. They are often leaders and strong voices in their communities. And so it's not a case of bringing in an idea that comes from the outside, but it's actually like supporting one from within. And I'll also share that, like, for many people, probably these topics are just uncomfortable to talk about, and that's understandable. And even now, I'm a sexuality education facilitator for middle schoolers through a private program I work in, and it's work that I love partly because it's uncomfortable, and I'm pretty comfortable talking about uncomfortable subjects and trying to create the space for other folks to enter into that dialogue and exchange and listening and learning and sharing. So yeah, there's lots of stigma, and there's usually somebody already within the community who is pushing to work past the stigmas.
I love that. I love that you help uplift the voices in communities that are typically against these topics. That's great. So currently you are the head of social impact at Yoga Alliance. How can practices such as yoga act as tools to help historically marginalized communities, not only in the US, but abroad as well?
So I love that you asked this question, because it sort of sums up why I ended up working in a yoga organization as a public health professional. It wasn't something that I had anticipated. I deeply honor and respect clinical medicine. It is important, it's necessary, and we're talking about like sort of Western medicine, it's sometimes called, or allopathic medicine. In addition to that invaluable source of healthcare, there are all these other complementary practices that can help improve physical and mental health. And some of them come with this bonus of being very accessible and lower in cost than certain clinical medicine. So yoga is this practice that's portable. It can be used by all people everywhere, and it has documented positive impacts on health and well-being. And that's what inspired me to work on yoga for social impact. Was I saw the public health data on how effective yoga can be, and especially for managing stress and trauma. So the communities that I've always worked with, within or for, bear disproportionate levels of stress and trauma, and that can negatively affect their health. So I spent years working on interventions that require complex care systems and medicine supply chains. And I was really inspired by this idea of a practice that could be helpful in navigating the difficulties of day-to-day living in a lot of communities that are economically, socially, and geographically marginalized. So I started working at Yoga Alliance, and just to share that Yoga Alliance is the largest nonprofit association representing the international yoga community. And what we believe is that if more people practice yoga, the world will be a better place. And we see the promise and possibility of yoga as this force for transformational change in individuals and communities, because it can shape how we manage life's challenges, how we relate to each other, and how we contribute to a more compassionate, more equitable, and more inclusive world. And that can seem really far apart from global health, but it's not, because again, yoga has documented impacts on physical and mental health. And so in my day-to-day work, what we're doing at this most fundamental level is we're starting by working to help spread the word, especially in the West, that yoga is a practice that's available to everyone, it's accessible to everyone, and that's at any age, in any body, in any place, or any circumstance, everywhere in the world.
So can you tell us some of your predictions as to what's going to happen in the global health field in the future?
This is such a good question, and I'd say I could make guesses probably better than predictions. So I think about this, I've got like really a couple of buckets, and one would be hopes. I'll share some hopes first. One hope is that there will be more attention and more invested in holistic and lower tech solutions for public health. So again, I believe in evidence and in data and in the need to measure and make sure interventions are effective, but sometimes we get really enchanted by complex technology, and there are a lot of things that can improve health and well-being that don't take as much money or stuff. So I hope that there'll be more of that. And there are some signs that there's more attention being paid both to complementary and integrative medicine, but also to solutions that come out of lower resource environments as being sometimes the best solutions. Another hope that I have, and there is some sign of this, is that there will be more equitable approaches to solutions and more investment and leadership coming from within the communities that are most in need of more healthcare resources and access. So essentially, less of a top-down person or group from the outside coming in and fixing something, and more of investing in the knowledge holders and leaders from within to direct that work. And lastly, and again, I'd say in hopes, but there is some sign of this happening, is more investment in the social determinants of health as a way to improve health and well-being. So examples would be investing in accessible and affordable and safe housing is a public health investment. That's just one of many examples, but really looking at all the things that are beyond the health system that affect people's access to healthcare. And in some of the environments I've worked in, it's literally like roads, transportation systems would make life-saving differences for so many people.
Things that we often overlook, right?
Yes, I mean, it's so easy to take them for granted. Even like a formalized ambulance system, not every environment has a formalized one, though plenty of environments have figured out how to create an ambulance system even informally. But like more investment in those things will change lives. Everything that I get to do and learn was really on the backs of so many people who have mentored and been generous with teaching me a lot, a lot that I had to learn about this space.
Definitely. Well, thank you so much for telling us about what you do, for enlightening me on so many things that I really wasn't aware of, or I haven't really given a lot of thought to. So that was very, very interesting. Thank you so much.
Thank you, Ankitha. It's been a pleasure.
You too.